good afternoon, everybody, and thank you very much, Dr. Radhika, Dr. Ochetti, and AIOS for giving me this opportunity. The word Gen Next here would not only imply the next generation of therapy, but also the next generation that we are bringing up, our children and the generation beyond. So I'll just run you initially through a bit of statistics about what related to myopia is the world and India's scene, and then what are the possible interventions that we are looking at. So first, the question that, and I've seen that and said that in many places, that for an ophthalmologist, myopia really means licking lips because it means a refractive surgery with a highly paid patient. But unfortunately, that is something that is troubling now the health service providers, because this paper in ophthalmology that came just some time back, which has predicted that by 2050, 50% of the world's population will become myopic, and is no doubt a very startling statistic, especially that 10% of them would be high myopes with their associated retinal and other pathologies that come with myopia. So up till just a very short time back, in fact, a few years ago, there was no real discussion of myopia in India, although it has now become a very serious problem in particularly East Asia, where they are using the term of an epidemic for them. But in India, it was never considered a cause for concern. We did this study published in PLOS One, where we did the prevalence in Delhi and nearby area, and we found it to be about 13%, which is nothing compared to the 50-80% that East Asia is actually showing. We found a cumulative incidence about 3 to 4%, which again is nothing compared to 10 to 14%, which East Asia is showing. So, well, in India, the numbers don't seem to be so scary. But then you go back and see in that same area in about 2001 or so, a similar study done from RP Center showed that the prevalence of myopia in that region was 7.1%. So in less than 15 years, or a little more than a decade, the prevalence has jumped from 7 to 13%. And it's very clear that Indians are really not immune to the problem of myopia. There's a lot of genetic variability that is being seen across the world, and that is helping us and pushing us towards some form of genetic intervention for them. However, Indian genes are not really immune. This was a very interesting study in Singapore, where they evaluated the prevalence of myopia in the first and the second generation immigrants. So the parents who came from India, settled in Singapore, had about 12 to 14% of myopia, and the very next generation, it jumped to twice to 28%. So it's not probably the genetic environment or genetics only that is really a problem that is causing myopia. So the other thought process, again, for us as ophthalmologists, myopia is really, the bulk, 90+% of myopia is really a benign disorder. But the moment we start understanding the problems with myopia, it's difficult to detect. We need to screen children, because more often than not, children are not easily picked up that they have a refractive error or significant visual dysfunction that will retard the learning ability. They tend to do poorly in school and sports, and they often suffer injuries. Of course, the associations of myopia in childhood is strabismus and amblyopia, and as they grow older, with increasing levels of myopia, you have pathological myopia with affective changes of glaucoma, with retinal changes which can actually cause irreversible blindness. And the other thing is about the economic cost. So this was a study about, in fact, this dated now 4 to 5 years ago, the economic cost of just providing spectacles, and we do not mean the refractive procedures, was about $4.6 billion in the US myopic population only. So when we look at that in India, and we add on the costs of refractive procedures, contact lenses, etc., we're actually looking at a huge economic cost for managing myopia in India. The basic risk factors, we know that parental myopia 3 times ups the risk for myopia in children. So if both parents are myopic, the child is very likely, 3 times as likely to be myopic. Again, this has given us a lot of work to do about the genes related to myopia, but although a lot of loci have been isolated, we still have not been able to identify any single gene, particularly for school myopia. There are a lot of genes isolated for syndromic myopes, but nothing really for school myopia, which of course is affected only by risk factors like parents. The other risk factors are that studies have shown that lower hyperope in age-matched versus age-matched normal. So we know that a child is born hyperope. The more than 90% or up to 95% of children are born hyperopes, and the hyperopia decreases with age as the emmetropization process progresses. However, children who are less hyperope for their age-matched normals. This 0.75 diopters is or less hyperopia for children about 6 to 7 years of age are the ones which are most prone to develop myopia with time. For an unusual reason, most places have found girls being more prone to myopia than boys. It's more of an urban problem, although in India we have recently done a rural study and we found the myopia has now jumped up in the rural survey from 3% reported again in 2001 to almost 7 to 8% in the last year when we did the survey. It's probably related to the constricted living spaces in urban areas, higher level of education. A very unique thing that we have seen, which actually nobody sees, our private schools, or public private schools as we call them in India, have a more than double or sometimes even a 3-time risk of myopia as compared to government schools. Now that could be associated with the socioeconomic, the background and the home environment also, but this has been consistently seen in all studies in India, and of course higher monthly income. The other major risk factor is the visual environment. So risk of myopia develops and progression is significantly associated with reading at very close distances. This could possibly be due to accommodation, although most studies do not list it as a primary cause. And the other thing is the light dopamine hypothesis, where increased time spent outdoors releases dopamine and reduces the elongation of the eye. So the visual environment, and of course associated binocular abnormalities, which includes esophoria and accommodative lag apnea. So myopes are known to have an accommodative lag. We are not sure whether it's a cause or a consequence of the myopia, but we know that they have reduced accommodative facility, they have an elevated AC by A ratio. So these are factors that are interplaying myopia and probably affecting their development. The one single clear protective factor that has been proven consistently across all studies is the role of outdoor activity, and our study and including numerous others now have shown that about 14 hours a week or up to 2 hours a day is effective, protective towards the development and maybe towards the progression of myopia. So this 2 hours means in the sun outdoors, not necessarily playing any sport. So 2 hours of outdoor activity may just include walking towards school, just standing in queues, etc. So bright light exposure possibly increases short wavelength effect and the UV light exposure, which prevents or reduces the release of dopamine and prevents elongation of the eye, and more uniform dioptric field of view across the retina. So we know that whenever we are indoors, however big the room, 6 meters is not infinity. So truly looking at infinite distances is what will prevent even that slight accommodation that can result in elongation of the eye. How do we prevent the onset? So we start with preventing the onset. So identify the pre-myope, low hyperopes, one or both parents are myope, children who are spending less time outdoors, increased near activity, and I guess now almost all children will fall into this category where they're indulging in reading, writing, tabs, phones. In fact, that's the single most biggest complaint parents give us. And of course, binocular vision disorders like accommodative lag, which are essential to be checked, and high AC by ratio. We need to increase the awareness among parents, go for risk factor modulation, and of course, outdoor activity. The other ways of preventing progression is refractive, correcting glasses, contact lenses, multifocal lenses, ortho-K, progressive ad lenses, and of course atropine, which we'll come to in the end. The spectacles, there is no evidence that optimal, under, or any kind of change in correction will affect the progression of myopia. A very interesting concept has developed about the peripheral ad spectacles, where we know that normal spectacles, while correct the myopia for the central foveal region, bring about a peripheral hyperopic defocus, which is probably the stimulus for development of myopia. And so we had the peripheral ad spectacles where the lenses increase in power as they go in the periphery. However, this is not well acceptable, and it also tends to limit the fields. The other thing is the presence of accommodative lag. So we know that there is an accommodative lag in myopes, and for that there are numerous studies that have shown that bifocal prismatic added lenses more than double the protection towards development or progression of myopia as compared to single vision lenses. So prismatic bifocals are currently significantly advocated for prevention of myopia. The first FDA approved intervention for prevention of progression of myopia are the Cooper Vision M-Sight lens, contact lenses that are a daily disposable lenses, and they have shown to decrease myopia by up to 40% and sometimes even up to 50%. So this is the first major effect that we can see that is now proven and shown consistently preventing the progression of myopia. The other effect is orthokeratology or ortho-K lenses, which also have in a lot of studies shown ranging from 30 to 60% prevention of progression, but ortho-K has major problems, and we haven't found them to be as acceptable among children in our case scenario. So we are still not sure how effective it can be. Pharmacological treatment, there was these landmark atom studies from Singapore, and which had shown that 0.01% atropine, which was actually their control arm, showed a significant reduction in the progression of myopia with minimal side effects. Unfortunately, in India, we've actually jumped the gun and it's now pharmacologically available, although it's still not FDA approved. We have a recent publication from the same group, the LAMP study, which has shown that actually 0.05% is a little more effective and no more side effects as compared to 0.01. So a lot of trials are underway, including in our country. However, there has been some work which says that probably atropine may not be as effective in whites as compared to East Asians, but there is no clear RCT outside East Asia, so we are yet to compile that data. We are hopefully soon going to publish our randomized control trial on the impact of 0.01%, and we hope to see how it affects. So this is kind of the overview, what today and what is in the immediate future for our generation next. At the moment, my site are the only FDA approved, but there are a lot of interventions that are possible. So where are we at the moment? I would say that outdoor activity, possible use of atropine drops, contact lenses, and ortho-K are the ones which are probably working. You can impact definitely, like Singapore has the slogan for every school children: keep myopia away, go outdoors and play. So there is something that we need as ophthalmologists to come together to bring about something good for the benefit of our generation next. Thank you very much.